more people will join after. So I would like to say a few words since this is the opening of the conference. First of all, hello everyone. Welcome to this session. Thank you for joining the opening of the Youth in Science Conference 2021. Most of you, if not all of you, know I'm Dr. Dimov, the chairman of Asclepius right now. And I would like to say a few words before we begin. First, I would like to express my gratitude to Associated Professor Delev, who is my direct predecessor on this position and who, we could say, paved the way of organizing a whole conference online. Last year, we did that for the first time. Still fighting the pandemic crisis now. Science in Youth 2021 is again online. I would like also to thank everyone involved in the organization of this event, although most of them are not online right now, but well, hopefully that will reach them one way or another. Everyone who helped me, the members of the board of Asclepius, the scientific committee, who were involved in the revision and selection of all the abstracts, the moderators of the sessions, of course, all the registered participants, and last but not least, our respected guest speakers. We have today Professor Plavec from Croatia. With all those people, I have been in active communication during the last several months, and I want you to know that without all your efforts, this conference will not be possible. Special gratitude I would like to express to Professor Blagoy Marinov, who is currently the Vice Rector for Scientific Affairs and also a predecessor of mine as former chairman of the Youth Scientific Association Asclepius. He was always very quick to react to all my questions and calls for help during the organization process, as always. I hope all the participants have familiarized themselves with the rules for participation in the conference and the sessions would go smoothly. The program is rich, it's quite packed, and we did our best to give many young scientists the chance to present. Traditionally, this conference is held under the auspices of the rector of the American University of Plovdiv, so this year is no exception. So our special gratitude goes to Professor Mariana Murjeva. She's here with us tonight, so I would like to give her the floor to say a few words, if that is okay.
Thank you, Dr. Jim. Dear colleagues and dear young scientists, it is my great pleasure and honor to participate in the opening of this scientific event, the conference Science in Youth. During the years, most of us know it became a tradition for our university, an event that brings together young people dedicated to science, an event that enables them to change ideas, to share their scientific experience, to make new scientific collaborations. This is the second time that we organize this conference in an online format due to COVID epidemics. And now I also would like to thank the organizers, Dr. Dimov, Dr. Delev, Dr. Marinov, for their enthusiasm to do that in these conditions. I'm sure that although we now are only 25 at the opening ceremony of this conference, probably will become more during the next 2 days, and this conference would be as successful as it used to be in the previous years. It is really inspiring for young scientists to receive good results at the end of the lab experiment or at the end of the clinical trial and to share it. And this motivates you to go ahead. So what I would like to issue is to have good start at the conference and success.
Thank you. Thank you, Professor Murjeva. So then, does Professor Marinov want to say something as the Vice Rector for Scientific Affairs and the person who was also involved in the organization of this event? I see that you're with us.
Hello. Dear Professor Murjeva, dear Dr. Dimov, it's a pleasure for me to encounter the second online Asclepius event. If you remember the previous year, that was the first scientific conference held in this format So I'm very pleased to see that we are keeping up the good work, and we are attracting more people eager to present. Without any more delays, I would like to give back the floor to you to continue with the program of this conference.
Okay, so thank you, Professor Marinov, and I think it's a good time now to give the word to Professor Plavec, who is going to give our first plenary lecture. We have 3 of them, so 2 of them are tomorrow. The program is available on the website of the university and the website of the association. So Professor Plavec, the floor is yours.
Thank you, Peter. I wish to thank also the organizers for inviting me for such an event. It's always a good thing when you can present, especially for young people, young scientists, young people that actually are the future of our business and research, especially biomedical research, which we see with this pandemic that has a great importance. I will here also present new data that were actually recently published, and they will have in the future, I think, terrific impact on the field where this was done. So this is about the lung function in small children. Do you see my slides?
Yes.
Okay.
Yes, and it's full screen. Everything is as it should be.
Thanks. So I will talk about impedance pneumography. Actually, the method of measurement, impedance pneumography, is quite old. It's not a new tool, but with some interventions in the methodology for the measurement and the analysis of data, this Finnish group of researchers actually made it a new tool to support clinical decision making for preschool children with recurrent wheeze. So this is my disclosure statement because I cooperate with many companies. One of it is it's also the producer of this technology. So what is the problem with the breathing problems in young children? The problem is that asthma is actually the most prevalent chronic disease of the childhood, and it presents with several phenotypes, actually also endotypes, and several of them actually disappear during the first 6 years of life. So the phenotype of transient wheeze and non-atopic wheeze actually disappear during the first 6 years. So the children have symptoms only during these first 6 years. The other two, like persistent atopic and seasonal asthma, actually persist till the adulthood. So it's very important that we can properly diagnose this condition. There is also a problem of differential diagnosis of respiratory tract that can present with almost the same symptom, and the main symptom of asthma in young children is wheezing. So there are a lot of differential diagnosis that can present itself with the same or almost the same symptoms, also starting with asthma, but even GERD like gastroesophageal reflux disease or immunodeficiencies could have the same presentation. So it's very problematic because you know that the lung function measurements needs cooperation of the patient. So young children below the age of 3, they can't cooperate with any of the methods that we have. So basically, we don't have means to do any objective measurements. There is also a problem that we can't rely also on symptoms, because parental observations are not reliable. And that's been shown in several clinical studies. Also, the physician's observations happen only once in a while when the patient comes to the physician's office, and typically not at times when the child would have symptoms, like night times while playing, running, etc. Also, asthma medication is not for prevention of the disease, but actually it's controlling the present symptoms, which actually, as you heard, may or may not be asthma. In small children, the empirical use of inhaled corticosteroids, which are used as the main drug to treat asthma in adults, is not encouraged because of these uncertainties. So before this new technology, the only thing we actually had in children below the age of 3 was infant whole body plethysmography with this rapid thoraco-abdominal compression technology, which needs sedation in small children. And this technology is actually available in very small number of centers throughout the world because it needs highly sophisticated and expensive equipment. It needs very specialized staff, and also the interpretation is very demanding. So it's really a cumbersome diagnostics that can be done only in a very small fraction of children that show symptoms. So it's not something that we could use on a global scale to monitor or diagnose asthma in small children. In this publication from 2007, it's the publication from Finland, where this group of researchers come. Even using this technology, it was not possible to show the difference between patients that had RSV bronchiolitis from those that could be asthmatics. So had a history of physician-confirmed wheeze due to non-specific etiology. So based on all this data, 3 years ago, actually a group that's called Lancet Asthma Commission is calling for objective measurements to decide who may have a disease which needs to be medicated with asthma drugs. And they also say that the lung function test should be used more universally than before, also for small children, in support of making a diagnosis and making decision who to treat and who not to treat. There are some newest technologies that actually help parents to see if what they hear from their child is wheeze, the main symptom of asthma. But the article published in Journal of Allergy and Clinical Immunology 9 years ago showed that also that's not the question. So a quantitative global assessment of significant troublesome lung symptoms during the first 3 years of life was a better predictor of asthma than the assessment of wheeze. So they say at the end that the right question should be to treat or not to treat. There is also a problem with measuring lung function because lung function behaves like symptoms of asthma. So it comes and goes. Symptoms of asthma comes and go. And also the lung function changes with it. So most of the time it's normal. And actually what we need is to be able to measure lung function on everyday basis to be certain that we can back up our diagnosis and back up our treatment decisions. So how can this technology that we already had before, and it's called impedance pneumography, how can that help us in that respect? So impedance pneumography, as I said, is the old technology which is used in ICU monitors to actually monitor respiratory rate. And this technology developed by a company Revenue called Ventica, it measures electrical impedance of the thorax. The same practically as ICU monitors do. The difference is that they did some improvements for that technology in a way that a special position of electrodes on the thorax was selected, and also they developed the algorithm that discards any troublesome signals, like you can see on this graph down there. The signal of impedance pneumography doesn't show the sinusoidal curve of the breathing in child. You can see the change in cardiac volume that also distorts the signal. You can, by using this algorithm, you can actually derive the flow from the volume changes. So as the lung volume increases, the impedance increases. And from that, the change of the volume through time will give you the flow. And they developed this proprietary algorithm that automatically discards distorted signals coming from cardiac action, movement, crying, coughing, talking, etc., other signals. This clean signal and this flow measurement accuracy was verified in different clinical studies, starting from healthy adults, preschool children, and infants, in which methacholine challenge was used to induce bronchial obstruction. So this is one of the studies which shows the data in 21 wheezy preschoolers that actually measured the impedance pneumography during tidal breathing simultaneous with the pneumotachograph that was connected with the mouthpiece. And during that, the child was in sitting position, only doing tidal breathing during methacholine challenge. On the A part of the graph, you can see that there is almost a linearity between the impedance pneumography signal and the signal that we get from pneumotachograph. So the results show high, accurate, almost linear relationship between the measurement done by impedance pneumography and the measurement done by pneumotachograph, and even despite this bronchial obstruction that was done using methacholine challenge in this study. So this technology is then used to actually analyze the variability in the shape of flow volume curves during tidal breathing. And what was shown when the measurement was done during the overnight sleep is that a healthy child shows a characteristically high variability in the shape of expiratory flow volume curves during nighttime tidal breathing. You can see that on this graph on the right. And this measurement is unobtrusive and comfortable for the child because there is nothing over the mouth or over the nose of the child, so there are no obstruction to the breathing. Everything is done only by the skin electrodes in the armpits of the child. So how that looks when there is a real life example. This is a 1-year-old patient. The left graph shows normal breathing during the night. This is the time when this patient was on ICS, inhaled corticosteroid medication. So you can see that there is a high variability of this flow volume loops. So there is a significant difference during the night. This is just a part of this overnight measurement. When the same patient was obstructed, when it showed obstructed breathing, this variability was very much narrowed down. And this obstructed breathing actually was recorded 4 weeks after the stopping of the inhaled corticosteroid medication, when this patient showed significant symptoms of bronchial obstruction. So this data, this variability of the curves, is used to calculate what we call EVI. That's the expiratory variability index, being a measure of the variability of this flow volume curves. And this Ventica software uses only the data that's recorded from periods of restful sleep and discards everything else. Clinical trials were done with this technology, and I will present also the clinical data coming from these trials. First one is the study that was published last year in February in Pediatric Allergy and Immunology, and it's called Reduced Expiratory Variability Index is associated with control and medication withdrawal and symptoms in wheezy children aged 1 to 5 years. So this is the study that recruited 68 children and 40 controls. So these 68 patients were aged 1 to 5, and the controls were the same age. They were all from Tampere, Finland. The patients had recurrent lower airway obstructions, thus fulfilling the diagnostic criteria for asthma. And based on the national Finnish guidelines, they were prescribed 3 months of inhaled corticosteroid treatment. At the end of this 3 months corticosteroid treatment, this ICS treatment was stopped, and the first measurement of impedance pneumography was done during the overnight sleep. Then the same measurement was repeated after 2 and after 4 weeks without the treatment. And these are the results. You can see that healthy controls show higher expiratory variability index than the patients that were even on treatment, so on ICS treatment. They show the slightly lower variability, and after stopping the treatment, you can see the significant within-patient reduction of this expiratory variability index that actually occurred, significant reduction occurred 4 weeks when compared to the start of the measurement and 2 weeks afterwards. Also, there was the other finding that children who were administered bronchodilator by parents' decision had even lower EVI values than those without bronchodilator need at 4 weeks measurement point. What was very good is the measurement success rate was 94%. So even when the parents were doing the measurement at home, it showed a very high measurement success rate of 94%. The other study was done in my hospital in Croatia, in Zagreb, and this was the study about the respiratory variability index and its association with the severity of acute bronchial obstruction in small children. And we recruited 30 patients, aged also 1 to 5 years, that were diagnosed and hospitalized because of the acute airway obstruction or asthma exacerbation, requiring inpatient treatment, and also recruited 39 healthy controls from Zagreb kindergartens. As you can see from this results graph, the healthy controls show the same high values of expiratory variability index as the population in Finland. And you can see by the violet columns that EVI was very low during the acute bronchial obstruction. So the first column shows 4 days before discharge from the hospital, then 3 days, 2 days, and 1 day before discharge. And you can see how this EVI is improving already during the hospital stay. And also what's important is to emphasize that these patients were on intensive short-acting bronchodilator therapy during that time. So even with this short-acting intensive bronchodilator therapy, they were still showing low values, showing obstruction. This EVI index was significantly associated with chest auscultation findings. So when patients showed wheeze, the EVI was low, and when the auscultation finding was normal, it showed high EVI. Also, you can see that after discharge, already 2 and 4 weeks after discharge, they show comparable EVI values to the healthy controls. What was also found in this study is that nasal congestion alone did not cause any changes and EVI, low EVI values. So in conclusion from this study, actually it showed that EVI is strongly associated with physician-confirmed bronchial obstruction and the severity of bronchial obstruction. EVI was low despite intensive bronchodilator therapy, which was in line with our previous study that I showed. It's quite dynamic parameter, so it shows changes with the change in the clinical presentation of the patient. It's being normal in most patients already 2 weeks after hospital discharge. So when they don't show any more symptoms of bronchial obstruction, and it was found to be a sensitive and objective marker of acute bronchial obstruction, showing strong association with changes in clinical status in VZ children aged from 1 to 5 years. The next study is, we wanted also to see if this expiratory variability index is associated with asthma risk and in infants with recurrent respiratory symptoms. And can this expiratory variability index in some instance predict what will happen with these patients? Will they develop asthma? So for this purpose, 36 infants aged 6 to 23 months with recurrent respiratory symptoms were referred to infant lung function testing at Helsinki University Hospital, where the measurements of EVI together with baby body plethysmography were done in these children. And what was found out was that lower EVI was associated with higher risk of developing asthma, modified asthma predictive index. So with the high probability of developing asthma according to the modified asthma predictive index, these patients show lower values of EVI. Also, compared with only cough as a symptom, the patients with having prolonged expiration on auscultation or wheeze showed lower values than only the patients who coughed. Also, this EVI was associated statistically significant with the lung function measurements done by baby body plethysmography. In this study, also EVI showed no association with nasal congestion, only as was shown in other studies, and the measurement success rate was also high, more than 80% of the measurements was successful. So the conclusion of these studies is that provided that the findings are repeated in larger cohorts of infants, this technique may prove to be useful and easy tool for objective assessment of respiratory symptoms in this age group, where lung function testing is very difficult and cumbersome and can be done in only as a very small fraction of patients. So how this technology fills in the gaps that we see in our everyday clinical practice. So for the first time, we have the objective data for children under 6 years, because according to the current practice, spirometry cannot be done because it needs significant cooperation from the small children, and other lung function tests are cumbersome. Clinical decisions based on little or no objective data are then problematic, and Ventica is now offering and is the only lung function test suited for repeated, even everyday routine use in any clinic for children under 6 years, and also it can be done at home, so parents can do it very, very easily. Also, it's for the first time a smart and simple tool that empowers patients and includes parents also in the treatment of their children. So in current practice, lung function tests are done in laboratories and result in sometimes in very complex curves, like for instance, for instance, impulse oscillometry, which can only be understood by the people specialized in lung function techniques. So you get graphs and complex curves and range of parameters that you have to decide, and it's completely not understandable for parents. But Ventica actually provides a simple, understandable one-digit result that parents can understand, and they can be now actively involved in the process of managing the child. Also, it can be done at home during the night when it doesn't influence the daily living routine. So the current practice of lung function snapshot that is obtained during office hours in a specialized lung laboratory, usually done on very seldom occasions, and in which the child cannot do anything if he has a cold. This is not the case with Ventica, so parents can easily perform Ventica measurements comfortably at home any night they decide or agree with the physician that's taking care of the child. Also, we now have the data supporting personalized treatment decisions. Ventica really supports treatment decisions with objective data, and EVI, expiratory variability index, showed to be a marker for bronchial obstruction, not being influenced by short-acting bronchodilators or nasal obstruction or congestion. So this offers actually better asthma control and quality of life, because regular monitoring with Ventica can improve long-term asthma control and make the child as lively as others. Also, we can stop the treatment when it's not needed, and this lessens the burden of giving drugs to the patients that don't need it. So when to use Ventica in clinical practice, what's our experience? Certainly, you can add Ventica to your clinical decision making, especially should when you want to decide if the child needs to start the medication. Low EV value supports the decision to use asthma controller medication in a child with symptoms, and in patients that are on treatment but still had symptoms. Low EVI suggests suboptimal control in symptoms, suggesting the increase of treatment, and a normal EVI may suggest an alternative diagnosis that should be considered. Also, this parameter can be useful when you consider stopping the medication. You can check medication adherence. You can consider differential diagnosis when you get the results that are not in line with the asthma diagnosis, or you can confirm recovery after exacerbations, which we clearly showed with clinical trials. In addition to clinical use, Ventica is really useful for drug companies' clinical trials in these age groups, which was not the case, and we know that a lot of drugs were actually not registered for these age groups, especially below age of 6. We have a very small number of drugs that are indicated in this age group, and none below the age of 2. So these are some examples where we could use Ventica to support what the diagnostic process and management. This first is the child, 21 months old, male, with recurrent wheezing and risk for asthma according to the asthma predictive index and family history. He was treated with anti-inflammatory medication, but with no improvement in symptoms. Had a suggestive history of asthma, but also enlarged adenoids. And we used Ventica to measure on several occasions during the 2 months his EVI values, and they were consistently normal. So the infant was discharged without the need for prophylactic treatment for asthma, and Ventica actually supported the clinical decision that asthma medication was unnecessary in this child, and the different diagnoses should be considered. Also, it can be helpful to support medication adherence. This was a child, 5 years of age, a male child, that had been prescribed medication for asthma, having an overprotective parents, and even though he was prescribed treatment, there was no resolution of symptoms on several controls when the patient was coming to the controls to our clinic. So we prescribed Ventica, and we, on the first occasion, we measured low EVI and prescribed treatment according to this, and also prescribed Ventica, and that seems to actually support adherence, because parents that now knew that we could see the lung function measurement in the child, and we could see on the next visit significant improvement in clinical presentation, both with the lung function measured by Ventica. Also, you can also support stepping up of medication. This is the other child, 24 months, with a suggestive family history and recurrent bronchitis, who was previously prescribed low-dose inhaled corticosteroids for asthma, but he was referred to our clinic due to continuing bronchitis, and he was prescribed Ventica measurements. So you can see that his measurements were sometimes in green and sometimes in yellow part of the spectrum, and it was decided that his treatment would be stepped up, and after this step up, at follow-up, good control of asthma has been achieved also with improvement in lung function that was measured by Ventica. What about the international guidelines? We are hoping that based on other data also, but not only this, things will become more visible on the international level. And this is the first publication that actually is a systematic review for the European Academy for Allergy and Clinical Immunology, clinical practice recommendation on diagnosis of preschool children about lung function testing and inflammation markers for wheezing preschool children. And under the part of new approaches, Impedance pneumography is mentioned as another promising lung function test, for instance, as a method that enables continuous measurement of tidal breathing volume curves during sleep using the chest impedance signal recording device. And the conclusion of this review is that objective measurement of lung function and airway inflammation is clinically essential to avoid over and under treatment of preschool wheeze and to monitor difficult to treat asthma. And we think that we are on the right track with this new technology to fill in the gap of objective assessment of lung function in this large group of pediatric patients that now have none. So in summary, we can say that impedance pneumography is a tool to support personalized treatment decisions for children with recurrent wheeze, that it's feasible and tested for children under 6 years, that is child-friendly nocturnal measurement that can be done at home. Basically, you can do it day by day. EVI as a parameter that we get from the measurement is insensitive for upper airway congestion, which is really good when we want to objectively measure lower airway obstruction, and is insensitive of use of short-acting bronchodilators, so we get the objective measurement of bronchial obstruction. It's objective. It's very simple to understand because it's only single-digit result, and based on data that I've showed, we found out that the children with bronchial obstructions have in 90% of cases EV value lower than 14, and children without bronchial obstruction, including those using current correct medication for asthma control exhibit EVI values of higher than 14. So thank you for your attention, and I'm now open for any questions that you may have.
Thank you for that talk, Professor Plavec. Is there anyone who would like to ask a question about this novel technology? I have some questions.
Okay. Shoot.
Okay, so first of all, as far as I understand it so far, this device is located in the hospital, and when you're testing children, they could take it at home, but it's not, for now at least, it's not intended as personal device, or that's the future plan.
Actually, it's intended to be a personal device.
That's the future plan.
Yeah, the problem at the moment is that it's quite expensive at the moment for personal use. So it costs like €2,500, and it's actually intended to be used by a prescription from the physician that is attending physician for the patient. So it's not to be used at the moment as a general tool like peak flow meter or something like that, that can be bought by a patient in pharmacy. So because we still don't have enough data to understand all of things, so I think it should be monitored by the data, and the measurement should be monitored by the physician and done in close collaboration with the parents, the decision making on the treatment plans and all this stuff.
Yeah, another question of mine was about price, which you already answered, and you display also results that it's very easy to work the statistics with that device, and there is a single digit that we get. You said that the cutoff value turns out to be 14. Could we presume that let's say, establishment of reference ranges is still ongoing, since this is a new method?
Yeah, certainly. We are now preparing a publication in which we will analyze all the data that we have from our healthy populations that were recruited. So there were more than 200 children recruited, healthy children recruited to actually produce normative values. And these normative values are not different, and they don't change with the age or the height of the patient. So this variability seems that it's the same no matter what the age or the height or the weight of the child is. It depends on the lung function.
Yeah, unlike spirometry, for example.
Yeah, unlike spirometry, yes.
Okay, those were my questions. Is there any other question from the audience? Well, I
just want to add the same principle of this variability and the narrowing down of the variability can also be seen in some other diseases, and it's been shown that, for instance, the heart rate is also narrowed down. The variability of heart rate is lower in cardiac diseases. So this basic principle, even though it seems that it's somehow different from what we could expect, that healthy would show a higher variability of this flow volume curves, it seems that this is different, and it actually follows the same pattern as in other diseases.
Yeah. Okay. So thank you once again. If there are no other questions, this was all that was planned for today. For all the other participants, I could welcome you again tomorrow at 8 when we start with the presentations. And once again, Professor Plavec, thank you, and hope we'll work together again in the future.
Yeah, thank you for the invitation, and I wish you all the successful meeting this next 2 days.
Thank you. Thank you. Bye, and have a good evening.
Bye.